Welcome. In today's masterclass, we will discuss the treatment of a 60-year-old female patient with a severely resorbed mandible wanting fixed removable implant-supported solutions. As we know, there are no two cases that are the same, and there are many options of how to treat patients. Like all my lectures, we speak in plain language. We show hundreds of detailed photographs with the objective of increasing understanding. The information herein is very technical, very graphic, step by step. The patient reported that she was 60 years of age and had all her teeth extracted circa 30 years ago due to caries. She also reported having 5 sets of full upper and lower dentures manufactured over the past 30 years and her current set of dentures for the past 5 years. The fitting surface of the lower denture had a soft reline material in situ and had been fully manufactured by a dental technician, and no dentist was involved in the manufacturing process or prescription. The patient also communicated that she was only able to eat soft food because her lower denture pressed on her mental nerves, and she pointed to that with her finger and reported that it was uncomfortable and made her remove and spit out her dentures. Small, equally placed holes were made on the fitting surface of the patient's lower denture and then filled with composite filling prior to taking an OPG. This treatment planning was taught to me by Professor George Nentwick. The final version of the surgical guide with the distal borders of the incision lines drawn in black and the implant sites marked in red ink. Ridge mapping of the 3-2 site at slice +6. At slice +10, the 3-3 implant site, ridge mapping. At slice +14, the ridge mapping of the 3-3 site, as discussed. The left side of the mental foramen, and you can see its proximity to the crest of the ridge. The right side of the mental foramen, and the same thing on the crest of the ridge. The secondary CBCT overview with the surgical guide in situ as discussed. The lateral Ceph view with the surgical guide in situ, an OPG with the surgical guide in situ at the initial appointment, the patient's charting with the 3 implants in position. This surgical guide, this was used in the patient's mouth when taking the OPG overview and in the secondary CBCT images as previously shown. An OPG with composite filling markers, these little balls were placed on the fitting surface of her lower full acrylic denture used for the implant planning. The patient's left side intraoral view, cast model of the lower jaw with implant planning sites replicated from the patient's lower denture. Cast model of the patient's upper jaw. The left side view with the patient's dentures in position. The right side view of the patient's dentures in position, the frontal view of the patient's dentures in situ, the intraoral view with the patient's dentures, this is of the lower denture in position, and the upper intraoral view with the dentures. The patient's laugh line, the right side intraoral view, the front extraoral view, the occlusal view of the lower jaw, and one can see basically just a flat ridge occlusal view of the upper jaw, an overview of the patient's maxilla in the primary CBCT, a CBCT overview of the mandible, the primary OPG. The post-op OPG with the 3 implants in position. This is a photograph of the wound closure with the 5-0 polysorb in position. Photograph of the 3 cover screws over the implant sites. Lower special tray, the impressions taken at implant level. Intraoperative impressions were taken of the implants in the 3-1, 3-2 and 4-3 sites and surrounding soft tissues. Direction indicators were placed in situ. Photograph of the inserted implants in the 4-3, 3-1 and 3-2 sites. Here is another view of the 3 implants in position. Design of the flap, which was T-shaped, so the initial incision line placed over here with the relieving incision, and also the position of the 2 mental nerves was identified. So you can see the proximity to the incision lines. Here again is the primary incision before the flaps were raised, and we have marked where the mental nerves are on either side. Pilot holes, an incision border marked with the pilot drill on the patient's lower jaw. Surgical guide in situ. Black markings indicate the maximum distal extension of the incision line, and the red marks the position of the osteotomy sites. This is a photograph of the wax try-in of the lower denture, pre-op try-in of the wax dentures. As a clinician, I am very conscious and mindful of having the privilege of working with live tissue on patients, and all experienced clinicians will understand the meaning of these words. Post-op radiograph control with the implant-supported bar and lower denture in the patient's mouth. The extraoral smile line, the extraoral front view. Prosthetic step, the video was confirmed at 65 millimeters. Occlusal view of the denture in the patient's mouth, lower denture. Same view showing hypertrophy of the patient's tongue. It is important just for a second to talk about this. This tongue is hypertrophied because the patient had such poor fitting dentures. This becomes an overactive muscle. And what happens in time, once the patient has an implant-supported denture, this tongue actually reduces in size, and we need to be mindful of this. So in the beginning, the patient may have some problems with that, but in time, this will regress and she'll be able to function as per normal. Denture in the patient's mouth. The left side view showing the dedicated lower denture access hole opening, which can be seen between the prosthetics teeth 3-3 and 3-4. Denture in the patient's mouth. The right side view showing the dedicated lower denture removal access hole opening, which has been placed between the prosthetic teeth 4-4 and 4-5. Dentures in the patient's mouth, the frontal view. Close-up view of the final fit of the implant-supported bar occlusal oblique view. Another photograph of the final fit of the implant-supported bar occlusal oblique view. Photograph of the implant-supported denture fitting surface with the yellow retentive caps, and we have placed 4 onto the bar and onto the denture. The final radiographic control of the implant-supported bar in the patient's mouth. The lower implant-supported bar, a close-up occlusal view, and we can see that provision has been made for 1, 2, 3, 4 male equator attachments and 1, 2, 3 prosthetic screws, and the bar has been specifically designed in this area here and over here to overhang the underlying mental nerves. So that actually is impossible for the patient to get any pressure onto her mental nerves when she fits the denture. Left side view of the upper and lower implant supported denture. The lower denture on the model, right side view showing the use of the dedicated denture removal tool or lever. This fits into this position, and then the patient presses down, and as she levers this down, the denture pops off on this side. She has to repeat that same process on the other side. Lower denture on the model. This is the left side view showing the use of the dedicated denture removal tool or lever. Same thing, it's positioned into the hole. The patient then pushes down towards her feet, and this pops the denture up. Left side oblique view of the lower implant supported denture showing the dedicated lower denture removal access hole openings, which can be seen between the prosthetic teeth 3-3 and 3-4, plus 2 dedicated removal tool levers. And I always provide the patient with at least 2 because they tend to lose them, and so at least there's an emergency spare one at home. The upper and lower denture on the model, frontal view. Lower denture on the model, occlusal view. The upper denture on the model, occlusal view. Prosthetic step of inspecting the upper denture fitting surface, a close-up view of this to make sure that there aren't any discrepancies, any sharp edges, any overhangs. Prosthetic step of inspecting of the upper denture, the fitting surface. Secondary try-in of the implant-supported bar, the occlusal view. Secondary try-in of the implant-supported bar, occlusal oblique view. The picture of the lower lab model. Picture of the upper lab model. Prosthetic step, secondary try-in of the upper and lower wax on the models. This is the right side view. Prosthetic step, secondary try-in of the upper and lower wax try-in on the model, left side view. Prosthetic step, secondary try-in of the upper and lower try-in on the model, frontal view. Prosthetic step, secondary try-in of the upper wax model, occlusal view. Prosthetic step, secondary try-in of the lower wax model, occlusal view. Prosthetic step, secondary try-in of the implant-supported bar on the model. And at this point, we specifically checked, because we had marked underneath here where the mental nerves came out, so we were able to check that the bar actually covered these areas. And finally, prosthetic step exposure step, the radiographic control of the impression copings in situ in the patient's mouth. Picture of a lower denture in the patient's mouth, occlusal view. A picture of the upper and lower denture in the patient's mouth, right side view. Picture of the upper and lower denture in the patient's mouth. This is the left side view. Picture of the upper and lower denture in the patient's mouth, frontal view. Picture of the patient's upper jaw, occlusal view, and we can see healthy pink soft tissues. Picture of the implant-supported bar in the patient's mouth, occlusal view, and once again pink healthy tissues. And by comparison, this is the occlusal view of what the patient arrived at our surgery originally with. And with that, she left for an international holiday. If you find our content valuable, we encourage you to like and subscribe to help us expand this educational platform. Remember that the path to good health lies in evidence-based scientific research. Stay tuned to our next masterclass, where we will dive into the topic, are dental implants safe, and provide you with valuable insights.